Welcome, everyone, to Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy practitioner. I'm joined today, as always, by a very amazing co-host, Dr. Jason Martin.
Pretty amazing.
He's a board-certified plastic and reconstructive surgeon. Dr. Martin, how you doing?
Doing pretty good. How you doing?
I'm good. We have a redo episode today. It's actually a two-parter. It's redoing everything you need to know about breast augmentation. And we're calling it Even More. So, cue the update.
Right.
Even more you need to know about breast augmentation, because as I told Nils, I sent this video to a patient recently and I was like, my goodness, we need to redo that. And I realized that there was a lot of information that the first two-parter is awesome, but there's even more information that I put in this one that's really good.
I feel like we just did that episode last week. So how long ago was that episode before?
It was 2 years ago. And I feel like
it right here.
I feel like it was like 100 years ago. So if you are not watching this episode and you would like to, you can find us on YouTube at Jason Martin MD. And we are on all social media at Jason Martin MD and at Beauty and the Surgeon podcast. All of our links are in the description box below. So without further ado, let's jump into even more you need to know about breast augmentation.
We should add a plus at the end of it, because the streaming services, when they have a service that's upgraded, it always has a plus at the end. So this is Breast Aug Plus.
Plus. Yeah, I was going to call it 2.0, but I guess plus works too.
We can. Yeah. It doesn't matter. We can do it. Just like Apple, we can change it all up. Let's go.
Oh my goodness. So this morning I was driving back from the gym and the Macy's across the street from our office has only 3 letters that are lit up. So it just says Mac. I'm like, oh my gosh, all the Apple people are going to love this.
Yeah, they're going to love it.
Yep, just Mac. All right. Fun story, Amy. So
that was very apropos.
It was good times. Yep. So let's first talk about the statistics. And we do have the updated statistics from 2024, which is awesome.
Crazy.
So it shows here that there was a slight increase in, and we're talking about breast augmentation for cosmetic purposes. We're not talking about lifts or revision or reconstructions. We're literally just talking about just breast augmentation. So if you had them redone or you had them done for the first time, that's what we're talking about. So in 2024, there were about 306,000 just done in the United States. And removals was an interesting statistic as well, was about 41,000. So far more people putting them in than taking them out.
It's just crazy. If you're looking on our YouTube channel, how it's been consistent year over year. And also, I feel like breast augmentation is the request for breast augmentation is going down. Maybe not in our practice, but overall, because that's what you kind of read and hear in some of the trade magazines. But it's not showing that in the numbers. I mean, the removal, you would assume that if removals would go up and requests would go down, but
not necessarily. I mean, those two things could be somewhat independent. Just because more people, it doesn't necessarily mean that more people are taking them out just because not as many people are having it done.
Right.
So, yeah. I mean, I think both numbers are pretty flat. I mean, a 1% difference, then the removal was statistically insignificant. It was only about 100 people, 160 people difference.
So I guess this really shows you that it's pretty stable.
And I think it has been. I mean, it's kind of one of those surgeries. I feel like it's a somewhat age dependent. So I think maybe that's what kind of keeps it more static. Because people tend to do it at the same age, whereas like facelifts and those kinds of things, people are starting to do younger and younger, and then they do them older and older because they're healthier. So I think that the time frame when people do this surgery is a little bit more condensed, potentially. And by the time they redo it, they're probably doing a lift or something else.
Right, and it's baseline, just with breast augmentation alone, it's the only answer for small breasts. Fat transfer is not going to probably get you big enough. So people don't really have other options either.
Right. Yeah, there's not an alternative. Same thing with facelift. There's really not either. Any of the surgeries we do that are definitive, there's really not an alternative.
You're destroying a whole aesthetics industry, Amy, with that comment.
Yes. Yeah, they also don't have an option for this. That's correct.
Yes, I am. I'm throwing shade.
Actually, what I'm doing is telling the truth, which is what they are not doing.
What?
All right. So looking at the difference here, that one of the interesting things that they did start doing in the last couple of years with the board is doing the gender affirmation numbers as well. So seeing those numbers, they stayed about the same also, just a slight significant or a slight difference in placement, and then in removal was the same thing. It was a 0%. So statistically insignificant, but interesting that we have those numbers to track as well, which is pretty cool. Yeah. All right. So like I was mentioning before, the age distribution with this surgery is a pretty definitive bracket from, in the United States, FDA approval for silicone breast implants, at least, is you have to be 22. You can do saline if you're over the age of 18. So you really do see that number start to rise after the age of 20.
It's so interesting. That's still the rule of the land.
Yeah, it kind of is. I mean If you're an adult, you should kind of be able to do whatever you want with your body.
I would consider 18 an adult.
That's what I mean.
Yeah.
Like you'd think that you could do whatever.
What data the FDA used for that recommendation?
Yeah, I honestly don't know that either. That's an interesting one.
Mm-hmm.
Yeah. And then Sarah did also put the removal numbers as well. And we see the largest makes sense, right? That starts to go up after the age of 40 is where that starts to go up. And we see that in our practice too. You know, a lot of women will have their implants, you know, and then they'll have pregnancies and weight changes and other things. And sometimes they'll just take them out and do a lift because they've got enough breast tissue.
And that's when you do the fat transfer, actually. So, which we do all the time.
Yeah. We do have an episode about that as well. So Nils, the breast augmentation without implants, I think we called it.
Okay.
Yeah. So that one is linked
Nils
there
doesn't remember. You're a terrible producer, by the way.
Well, it's been a long time ago. All right.
Again, every episode to me was last week.
Yes.
But I guess my time management is not working.
It isn't for any of us. So Dr. Martin, what are some things that a breast augmentation can do?
Okay. So number one, I think the main thing is that it can increase volume by primarily increasing projection on your breast. So
Size. Makes them bigger.
Yeah. So the size and the size somewhat, appearance of size somewhat correlates with projection, but definitely makes them bigger. One of the things Amy put here, which is absolutely correct, and it's pretty common, is increasing symmetry or balance. A lot of people, even before pregnancies, their breasts are, you know, what do you say? Just cousins, not identical twins?
Sisters.
Sisters,
They're
not
sisters, not twins.
Okay, sisters, not twins. So you'll see that the breast augmentation is really helpful for symmetry purposes. Amy also put on here, it enhances self-image and confidence, and that's for sure.
Well, that is a double-edged sword.
Until you read, watch our episode, where it says it does not. I think anecdotally speaking, at least in our office, for people that struggle with smaller breasts, asymmetric breasts, or imbalance, that's like the biggest thing.
Well,
like,
that's why I put improves your breast to hip ratio.
Yeah.
You know, because that's really, it just brings balance back to the body in a way that really nothing else can. I mean, if you're bottom heavy, there's not a lot else you can do to kind of give yourself that hourglassy look without doing something to make your chest bigger. The downside of that is that you don't want to end up looking like a linebacker if somebody is narrow on the bottom. And that's where we'll talk about that with implant selection. If somebody's really narrow hipped and you put really big implants in them, then it does the opposite. It makes them look like an upside down.
Yeah. And I know we'll go over this, and we went over this in the last episode when we covered this topic, but for sure that depends on the surgical plan. And also for the selection of the implant is so important. In our office, we do it with the patient. So it's a combined team effort, but you have to select the right implant for your body to balance it out.
If that's what you're going for.
If you're going for it. Now, we have patients that come in that don't want balance.
Yeah.
They want to have narrow hips and really, really large breasts. I mean, that's their prerogative. But in general, most people want to have some sense of balance. Also, especially if you're shorter, not having balance can lead you to look more heavy, which is not a desirable outcome. So that kind of stuff. The last thing that Amy has on here is droopy breasts. So the implants will not.
That's what it can't do.
It cannot correct droopy breasts. That's one of the things we get all the time in our clinic. People come in, they have droopy, deflated breast after pregnancy, and they think an implant alone is going to solve that problem. Rarely it does. If you have any kind of ptosis or droopiness of the breast where the nipple and areola is below your inframammary fold, you can just look that up, but it's not going to work with an implant alone. In the old days, or even now, still people will put in super large implants and blow out the breast, so you don't have to do a lift, but then you're going to end up with a lift 2 or 3 years later. So it's pretty inane to actually do that. And actually, I don't view favorably those surgeons that do that kind of stuff. I think it's unfair to the patient personally. And it's hard to fix because we fix these kind of things. So it's not, if you have droopiness, notable sagginess of your breast, the implant alone will not fix it. You will need a lift also.
Yes. And something I didn't put on here, but that is true, you know, well, yes, it's true that breast implants can definitely enhance your self-image and confidence. It does not fix bad relationships.
Yeah.
It will not get you a husband. Like those are things that it cannot do. And unfortunately, we see that, you know, we see a lot of people come in who are maybe not a lot, but occasionally we'll see a patient come in who is being pressured potentially by their significant other. And that never ends well. So
and it doesn't usually go over well in our office either.
No, like those are not our people. But, you know, I mean, ultimately, I think most people understand that this is the one surgery we do that I've said this before that is like instant gratification.
Oh my God.
Like it's instantly different.
It has that chat GPT quality.
Yes.
Like it's like within, 1 hour, everything's different.
It's different. Yep. Which is awesome. Yeah. All right. So this is what we didn't really deep dive into in our first episodes about this. And we're going to talk about what you need to know about breast implant safety. And I'm going to start it off with this that say the majority of women with breast implants will not experience serious complications. And that's true, statistically true. However, there are risks associated with breast implants, and these are things that are only associated with breast implants. So if you never have breast implants, you will never have any of these conditions, even as a potential. So simply by having breast implants, these things come up as potentials. And again, they're extremely rare. And I did put that. So 3 things we're going to talk about, and we've had a whole, and this episode's going way back, like pre-2020.
Here it is, Nils, this one.
About the FDA's new...
risk with breast implants.
Breast implant complications.
Breast implant complications.
I think it's controversies.
Controversies.
Isn't it?
Come on, Nils.
Yep.
Breast implant controversies. Yep. I told you that.
Yes. So this was back, I think, in 2019 when the information about BIA-ALCL initially kind of started coming into the more well-known realm, which is breast implant associated anaplastic large cell lymphoma.
2018, 2019.
Yeah. We're also going to talk about BIA-SCC, which is breast implant associated squamous cell carcinoma, which is even more rare. And then also about breast implant illness, which is just a group of symptoms, essentially.
It's a catch-all for certain symptoms.
Yeah.
Yeah.
So let's first talk about BIA-ALCL. So this is not breast cancer. It is a lymphoma. So it is a cancer of the lymphatic system. It's extremely rare. As of recording, there have been 1,577 cases reported worldwide and 63 deaths. These are primarily in textured implants, but there have been reported cases in all types of implants, including smooth. It's often curable when diagnosed and treated early. Treatment includes removal of the implants and the capsule. And I think everything we said in our breast implant controversies episode, like the treatment, is removal of the implant.
Yeah.
And it's going to be the same way in this.
So real quick on this. Go ahead, please.
Oh, no, I was going to say, do you want to talk about the symptoms and the diagnosis
that's what I was going to talk about.
part?
Yeah, good.
Yep.
Look at you. We're always on the same page.
We are. Yep. I covered the base. You get to talk about
you
what
sum
someone
it up
might...
and I hit it out of the park. Okay.
Yes.
The presentation, and this is fairly consistent, is going to be swelling of a unilateral breast. So if you have a history of breast augmentation, specifically with textured breast implants, and the ones of concern weren't every different type, but all of them have had at least one episode of ALCL with it. You have swelling on one side of the one breast or the other. And the first evaluation of that should be an ultrasound to show there's fluid there. And then that fluid should be sampled if possible. You could also get an MRI, which is what's done. But once that fluid is sampled and evaluated, and Amy, you want to go into what they're looking for when they evaluate that, or not really? So it's a T-cell mediated lymphoma, and it's looking for a specific cell line, a clone of the T-cell line that is present in that fluid.
I think in our episode about that, you spelled something and not cytology.
Yeah.
What, like histocytology?
I don't even know.
But that's what they said it
Why
up
do
for.
I do that?
I know, it was so funny.
I'm always so aware about medical words, and I spelling it out. It's going to make it any better for a person.
Well, it can if somebody's searching for it.
I guess so.
Yeah, knowing how, cystology is something that we say a lot, but it's,
cytology, cystology. Yep. So
didn't you just spell the very beginning and then say tology?
Yeah,
I think
you like to.
S-I-S-tology.
Tology.
Okay, guys, come on. I'm the doctor here. All right. Anyways, but you can have swelling of the breast. You can also have masses. That's one thing that they've found. You can have lymph nodes that are enlarged, usually on the same side or ipsilateral side of that swelling. And then you can have hardening of the breast too. These are all signature presentations of ALCL, but what is definitive is almost always swelling and fluid around the implant. So just remember that. So if you're someone watching this episode and you have swelling of one side or the other, I don't care what implants you have in there, cosmetic or reconstructive, and you have swelling, then you need to be evaluated quickly or immediately. So,
can I jump in real quick?
Please.
Because you said something important that I want to make sure people understand.
Yep.
Because we're talking just about primary breast augmentation. However, because this is not breast cancer, if you have had breast cancer and have had a reconstruction, it doesn't mean that you can't still get ALCL because it's not related to the breast tissue. So that's why when you said that, the reconstruction part, do not ignore that either. Because if you have swelling, it's not breast cancer.
That's a really good point. Yeah. So swelling, ultrasound's the first step. Hopefully, if you do have fluid, they can somehow draw that fluid off without hitting the implant, which can be problematic in certain places. MRI maybe. And then in some cases, you just take the person to the OR immediately and take the implants out if you're really concerned about it. Now, the treatment of it, though, go ahead.
Well, have you learned anything more about the genetic connection of these specific mutations that they look for that might make people at higher risk?
Not really, at least on the reconstructive side.
Yeah.
That's for sure. I mean,
Because
obviously,
both BRCAs come up as being higher.
BRCA1 and 2 for sure. TP53. These mutations, I've seen before on the reconstructive side. But no matter what, the treatment of BIA-ALCL is removal of the implants.
And capsule.
And the capsule. And just so you know, and we mentioned this before, the lymphoma itself actually comes literally from the capsule. So the capsule is the body's inflammatory response to having an implant in its like soft tissue. The reason that textured breast implants form capsules more and more inflammation is that some of the texturing that was used in the previous implants inherently in certain people, and that may be related to their genetic background, cause more inflammation than the average person.
Well, or the biofilm theory too, that there's
for a capsule formation.
Yeah.
And then chronic inflammation in any situation can lead to things like lymphoma. So that's really what's going on. And remember, T cells, I mean, not that people took immunology classes, but T cells are part of that inflammatory response. So it's this smoldering fire of inflammation around the implant for a long period of time that then switches into this T cell clonal line, which is consistent with ALCL. But if you take the implant out, you do a subtotal capsulectomy, take all the scar tissue out, in a high number of cases, that people can be cured for sure.
Yeah.
And the people that died, I mean, some of these people had other health problems going on. So 63 deaths out of 1,500 cases seems like a lot, but we don't really know the past medical history of those people that passed away.
Well, and how long it took to be diagnosed. I mean, that's really what's key. And that's why I said it's often curable, and without any other treatment other than just removing the implants. In some cases, if the lymphoma has spread, or if there's lymph nodes involved, then there may be additional need for radiation or other types of treatment. But a lot of times just taking out the implant fixes it. So, I mean, I think that just shows.
And the capsule, which is really the insulting part of it.
Yeah. Kind of the innate ability, like you said, of the body to kind of, it's something that it's triggered by, but when you take that trigger away, it goes away. Yeah. Which is unique.
Capsulectomy. So we do this all the time when I do revision surgeries. For ALCL, you're supposed to do a total 100% capsulectomy if you can.
Yeah.
So I get people come in all the time. They don't have evidence of ALCL. They're going in for an implant exchange and they read on the internet about ALCL and they're like, I want all my capsule gone when you do this implant exchange, which can be very destructive and actually cause cosmetic problems afterwards. So what I tell people is I'll take out a big part of the capsule, but not every single bit of it, which can be a disaster for people that have real thin, soft tissue, like minimal breast tissue, loose skin, and then you start taking a capsule out, you could cause real problems if you do a total capsulectomy. So,
and your body will reform a capsule. That's
the other part of it. Yeah.
The capsule is a normal part of the body healing. There's a capsule around every implant. And we say that in our implant controversies episode, every implant has a capsule.
Right. No matter what implant it is, even like a knee replacement
Exactly.
implant.
So the treatment does not include exchange. The treatment includes removal and not putting implants back in because your body will form another capsule. So Dr. Martin was talking about cases where someone who's doing a breast implant exchange, you can take out some of the capsule, it's going to reform it. But in cases of BIA-ALCL, it would be very against recommendations to re-implant that patient.
Absolutely. It's not recommended.
No.
That would be malpractice.
Exactly.
But I want to say again, people go on and they're like, oh, I want to do a revision breast surgery. I want to do an implant exchange. I realize that my implants are too small or too big or something. And then which we encourage, they do their research and like, oh, what is this ALCL thing? I mean, it only came to our zeitgeist about 2018. So what is that, 6 years, 7, 8 years? It's been, people have been even talking about this. Yeah. And then so instinctively they say to me, I want all my capsule out. I don't want this problem in the future.
You're going to develop another capsule.
You're going to develop another capsule and you just can't do that in most cases because it would cause severe problems.
Yeah.
But that was good to review this again. Thanks.
Yeah. So we're going to take a quick break and then we're going to come back and talk about the other two things and some more about pre-op and all that good stuff. How to find a doctor.
Yeah. Let's do it.
we're still talking about some rare things that could happen with implants. The next one being extremely, extremely rare.
Yeah, I don't know much about this, but it's so rare.
Yeah,
And I think they only came out with these kind of recommendations in the past 2 years with BIA-SCC.
Yeah, so that is breast implant associated squamous cell carcinoma. Again, this is not breast cancer. It is extremely rare and it's found in any type of implant. It can be very aggressive and it's actually in the capsule itself. So this is not a fluid thing. Like it doesn't form fluid. It actually is like forms in the capsule. And any of these weird, we had that patient years ago. Remember she had that surface spreading squamous cell carcinoma like on her foot. I mean, these squamous cells do really weird things, but they've figured out that that's what it is. It's these, you think of squamous cells, you think of like skin cells. Well, these squamous cells also kind of form in and around the capsule. Like your body puts those same type of cells there and they can be very aggressive cancers. So they are extremely rare though. I mean, 19 cases.
Right. And just FYI, you can have a cutaneous T-cell lymphoma of the skin that is exactly similar to what happens around the breast implant. And obviously you can have cutaneous squamous cell carcinoma. Anyone that knows anything about skin cancer, I mean, it's basal cell is the most common, squamous cell is the second most common. So anyone listening right now may have had a squamous cell. It's treatable. So these are all kind of following in line. And I bet you of these 19 cases, these people probably have immune issues.
Yeah, something else going on.
If you see people that are immunocompromised, they have much higher incidences of skin cancers and other types of cancers.
Yeah, because our body just can't fight stuff off.
Or a genetic problem that doesn't allow it to, see some, mutation.
Right, they aren't flagged by the system, by your body.
Right, that it doesn't kind of lock it down and get rid of it. So very interesting.
Yeah, symptoms can be the same though. Breast enlargement, pain, asymmetry, a lump in the breast or in the armpit, a skin rash, hardening. There still can be fluid around the implant, but it's different. Treatment includes removal and removing the capsule. And again, not re-implanting, like taking them out and being done. Yeah. So breast implant illness. This also became a huge topic about 7 or 8 years ago.
It's still a huge topic.
It is. And it's challenging because it's a wide range of symptoms. It's can include things like joint and muscle pain, chronic fatigue, breathing problems, sleep issues, rashes and other skin problems, dry mouth and eyes, anxiety, depression, headaches, hair loss, GI problems, memory and concentration issues. So, all those things I just said can be the same.
I have BII.
Right.
What about you?
Can be the same or similar to other conditions, autoimmune conditions, connective tissue disorders, chronic fatigue, thyroid problems, Lyme disease, menopause, so it becomes really challenging. Because like I said, we all feel like, oh, well, yeah, I have some hair loss, I have a headache. But these are things that like you when you rule out everything else, then maybe you could start to think that that's what it is, because you don't want to ignore these symptoms and just be like, oh, well, it's just my breast implants that are causing this. You want to make sure that you don't actually have something else going on. So you definitely should not ignore these problems or just brush them off as being like, oh, it's my implants, that's why I have headaches all the time. Like, no, you need to get that checked.
My frustrations aside, I feel for these patients immensely.
Because these are real symptoms.
These are real symptoms. They feel this. They present with symptoms. And Amy and I both want those patients to be heard and recognized and appreciate the fact that they are struggling. The problem is that the list of possibilities that could cause these problems are so numerous. And what usually happens with these types of patients, they go through this whole litany of tests and nothing really shows it. They end up in our office and we're like, well, let's just take the implants out and see if you feel better. Obviously do as much of a capsulectomy as we can. And in our experience, this is very anecdotal, people do feel better afterwards. Now, it could be all placebo. I don't care.
But placebo's real.
Yeah.
Like if it's placebo, it's real.
I'll take placebo every day.
Yeah. And it is challenging because to think, I mean, we just talked about 2 really serious things that can happen because of breast implants. So to then say like none of these things could be from them would be ridiculous.
Right.
Because what we said was that, a lot of the issues that come from like ALCL is because your body is having an inflammatory response. Now that inflammatory response in someone might be to develop ALCL. It might be to just have dry mouth or constant rashes. A lot of the social media buzz is around people who have really extreme weight loss resistance, and then once they have their implants removed, then they're fine. So, the time we had a patient who was actually the very first patient we took her implants out on was referred by her rheumatologist, was the one who finally said like, hey, I think that this may be contributing to your really bad RA symptoms. You're still going to have rheumatoid arthritis regardless, but maybe this is making it worse.
And why not?
Yeah.
Yeah. I mean, it's pretty easy to take implants out.
Yeah.
Yeah. And I always look at it this way. A big thing right now, and I'm not sure how I feel about this, is mold exposure. And people come in with chronic fatigue, breathing
Headaches.
issues, sleep issues, rashes, skin problems, dry mouth.
Memory loss.
Memory loss,
Yep.
headaches, everything that you're seeing here. And this is say that that's real in most of these cases. I'm not sure about that, but this is for postulate that it is. Well, a chronic inflammatory insult is going to lead to all these problems over time.
Exactly.
It's
You have
going to
mast
rev
cell
up your
activation.
inflammatory system, your component system, and then it's going to lead to all these secondary problems. So if there is a chance that you're having inflammation problems from your implant, get them out. It may not solve the problem. You may not like how it looks with them removed, but at the very least, you check that box. And I think that's really empowering for these patients.
Well, and that's why I want to make sure that people do their due diligence first. Like you make sure you don't have Lyme's disease. You make sure you're not just having something else go on because it can be shocking to remove your implants. But the thing is, if you take them out and none of your symptoms go away, you can always put them back in.
That's a tough sell.
Yeah, so
Yeah.
Has last 4 years, long COVID has been this big thing that sounds very, a lot of vague symptoms that everything has that changed.
No.
Like kind of what like people, haven't like gotten away from this and
Nope.
thought it was that or anything. Interesting. That's
Yep.
another hard thing to
There's
diagnose.
clearly things going on in the cohort of people, especially in this country, of chronic inflammatory problems. But I don't think healthcare is caught up to understand what the hell is going on with these people.
Yeah, and there's no diagnosis code for this condition.
Yeah.
It's kind of like when fibromyalgia
Yeah, fibromyalgia.
took forever to actually get a diagnosis
Right,
for.
because fibromyalgia is like a catchphrase or a catch-all for a group of symptoms. And then the treatment for that often is antidepressants. Well, that doesn't really
Right,
make
and
a lot of
gabapentin.
sense. And gabapentin,
Yeah.
which is Neurontin. So I think that you're hinting at something that I've, at least from my perspective, again, I'm a plastic surgeon. I'm not an immunologist or rheumatologist or something, but I think the COVID vaccines and the discussion around that, and then COVID itself with long haul COVID, has really opened people's eyes to chronic inflammatory conditions.
Right. Yeah, that if you don't stop this process, it will persist.
Yeah. And I think that's somewhat forcing the medical community to try to figure out, okay, how can we label these people and get them treatment? Sometimes that process of wanting to help them and label them puts them into a bucket that really is not what's going on with them, like mold exposure, But I've met so many patients that have been diagnosed with either like mold exposure or fibromyalgia or whatever, and they've got treatments and they feel better. So I think that's a big part of it, is trying to quantify what's going on and then trying to have a systematic way to treat these people. In the end, though, with BI, if it's perceived BII, in almost all cases, they've worked through the differential. So does that make sense? Yeah. So you've seen someone who's more like a specialist in most cases. So now we get patients in here that just want their implants out and they feel like it makes them feel bad, but they don't have all these symptoms.
Yeah. Or
That's not BII, but they just want them out. And we 100% support that too.
Yeah, I think I said that I've said that in many episodes about breast implants, and we'll talk about that. They're not lifetime devices. Like put them in, take them out, put them in again. It's okay. You can do that.
The hokey pokey. I think that's what we said before.
Yeah. All right. So what are some other important considerations? Like I just said, breast implants are not a lifetime device and may require one or more surgeries in the future.
But I thought it's supposed to last forever, Amy.
No, they are not.
What?
Yep. Breast augmentation also requires regular examinations of not only your breast health, but also the condition of your implants.
And how would that happen?
This is done via the FDA recommendation of a MRI screening. So current FDA recommendations, and this is in 2025, are to have an MRI or ultrasound. They actually say MRI or ultrasound now
What?
because the 4D ultrasounds are so good. The breast ultrasounds they're not covered by insurance, but they have way less exposure to a lot of things, and it's a great option.
And, well, I mean, the MRI doesn't have exposure, but it's to lay in that tube.
Yeah, for people
Which
who are
is miserable.
claustrophobic.
Yeah.
But
So the ultrasound is great. Amy's the one, of course, always brings this stuff to my attention with the 4D ultrasound. So
yeah, really cool.
historically, ultrasounds haven't always been great because it depends on the ultrasonographer, the person using it. But I guess the newer technologies give you better visualization and can show ruptures better.
Well, and it can also show the breast tissue itself, which is what ultrasound really couldn't see before. It was kind of just seeing soft tissue in general or liquid. It could kind of see the difference sort of, but not really. So that
But no matter what, MRI is the gold standard, no matter what. So if it is recommended by the FDA and by my professional society, MRI. But I agree with Amy. I think you could consider an ultrasound, but you got to do the research on your own.
Well, that's why I said that this is directly from the FDA.
Yeah.
They have added ultrasound to the recommendation. So MRI or ultrasound within 5 years of implantation, and they actually say 5 to 6, but I'm like, why say 5 to 6? Like within 5 years. And then every 2 to 3 years after that. And that's different than your regular breast screening. So this is literally just to look at the implant itself. Other important things to consider with breast implants: pregnancy, weight loss, aging, gravity, hormonal changes may all influence the appearance of your augmented breast.
Son of a bitch.
If only we could stop aging.
Avi, what is going on? Can't we just stop everything where it is? Just freeze it.
Gravity too.
I was going to say, like, that brings with it a whole host of problems. And my immediate thought to that was like, we'd all be hitting the ceiling. Yeah.
We're all floating around.
Yeah, we'd have no business. So.
We've had a few patients who like sleep, I think, in bubble wrap because they refuse to get a wrinkle on their face, and they look great. So maybe it does work.
Maybe.
Yeah.
Yeah. All right, Dr. Ryan, who is a good candidate for breast augmentation?
As we always say, healthy enough for surgery is the first thing for elective procedures. So if you don't have a lot of past medical history issues, you don't have heart problems, you're active, you're non-smoking, you live
also includes vaping.
Healthy lifestyle. By the way, vaping is smoking. Mm-hmm. Yes.
It is smoking.
And by the way, if you vape marijuana, that's technically bringing in chemicals into your lungs. It maybe not nicotine, but it's probably not great for you, and it's probably not great for healing. Just my opinion.
Yeah.
Your breast should be fully developed. That's why they want people to wait at least till they're 18. Mm-hmm. So every now and then we'll do breast augmentation in people that are younger, but they usually have congenital issues like Poland syndrome, which is what we talked about before, severe asymmetry and things like that.
Yeah, like complete amastia, meaning one breast just absolutely did not develop at all.
Right. We've also done breast reductions on people less than 18, obviously, because they have gigantic breasts, literally, and it's physically debilitating for them. So, but the FDA recommends or requires that you wait till you're 18. That's a saline implant, and then over 22, right? Yep, 22 years old for a silicone implant. Yep.
You should not be pregnant or breastfeeding. And in most cases, we're going to want someone to be non-breastfeeding for at least 6 months because that breast tissue needs to have a chance to like go back to its normal size. And the tissue kind of needs to respond.
Some people will wait 3 months. I think that might. It just seems like that's kind of pushing it.
Like, why not wait 6? Like, why not wait for it to really have a better outcome?
I mean, all you have to do is ask a woman who's been pregnant what their breast, how long did it take for their breast to get to their whatever state they are in. And they're going to say 12 months.
Yeah.
They're not going to say 3 months.
No.
So, I mean.
And just hormonally too, it's tough to have a surgery right away again after you've just given birth. Like that's a lot on your body.
Also your weight regulation. Yeah.
That's what I mean. Like
where you end up as it just doesn't make sense to do it right away. I get the reason they want to, because they just want to fix it. Okay.
Yeah. Yeah, that a lot of people want to fix things though. That's the thing. If you have asymmetrical breasts, you are also a great candidate for a breast augmentation. As Dr. Brent mentioned, like you can have one breast that doesn't develop, like those are, you are absolutely a candidate. If you have one or more breasts that just failed to develop normally, we've seen that as well. It is unusual, but it happens. We've had patients who have
multiple cases.
Severe amastia. Mm-hmm. The other thing too is you need to have a positive outlook and realistic body contouring goals. And that is kind of goes back to what we said initially, like no surgery is going to fix your life. It'll make the good things gooder, but it can also make the bad things badder. So having a positive outlook and realistic expectations is also key.
Right. For all the surgeries we do, but especially this one, it is awesome because it's so instantaneous. And the other thing I like about breast augmentation, at least in our office, is we really work with patients to see what examples are to help us select the implant. So it's really like user friendly. They're very involved. With face and neck lifts, I mean, I could show them in a mirror, but it's just hard to kind of wrap your head around that kind of three-dimensional change.
Well, but they've looked like that before. That's what's a little bit easier because they know what they used to look like.
But the breast augmentation has that like almost instantaneous quality, which is like very infectious.
Yeah, it is good.
And Amy is a implant savant. She'll break it all down for you. Tell you exactly.
Oh my God.
Exactly how it's going to come out in the end and everything. It's pretty cool.
So I have to tell you, I mean, this is a side point, but there's so many times I'm in the OR. So the way we do things is I'll see a patient. I have a number in my head. I don't say it. Amy comes in, and like every single time we're in the same range. And we've worked together so long. rarely are we apart. And if we are apart, it's maybe like 5% volume difference. So it's inconsequential. Usually when we're apart, Amy's talked to the patient more. So understands what they really want. Like they say one thing to me and then they tell Amy what they really want, kind of thing. Anyways, but like I've done cases where I'm like doing the surgery and I'm like, oh man, I'm not sure if this number that we talked about I have in my head, I think I want this. And then I just look over and the implant's sitting there. So she has this ability to like project in the future to like give me backup numbers, like, which is so crazy. That's crazy.
Mm-hmm. Well, that comes from working with somebody for 18 years and looking at a lot of breasts.
I know, but if you could take that on the road, maybe
you can.
Start a reality show.
Unfortunately, it is not a marketable skill.
You could monetize that.
We do. That's what we do. We do.
Practice.
Yes.
Yeah, we do.
Just like brachioplasty pays us. It does.
Yeah, it does pay us.
Yes.
Thank you, brachioplasty.
And we'll talk more about implant selection in part 2. For now, we're going to talk about how to choose a surgeon, because this surgery it's easy, right? This is not rocket science. This is not like a facelift.
If you see a plastic surgeon and they're trying to, equate a breast augmentation to a face transplant, then they are absolutely trying to sell you on something.
They're overselling it.
Yeah. Now we do all the new techniques. It's very elegant. I'm really prideful about my breast augmentation results, but on a scale of 1 to 10 of technical difficulty, this is like a 3. And that's doing fat transfer and internal bras and anything and everything you've read on the internet. A 3, maybe a 4 of difficulty. 4.
Not for a straight BAM. That's never going to do a 4.
Well, I mean, I don't know. Yeah, I'm just saying for an experience or someone with a reasonable experience, board certified plastic surgeon.
Yeah. So it does matter though who you choose, because your outcome is going to be very dependent, and that's why, as we say in every episode, you want to make sure you find somebody who's board certified by the American Board of Plastic Surgeons or the Royal Canadian Mounties in Canada. There is no American Board of Medical Specialties that recognizes a board with cosmetic surgery in its name. So if your doctor is calling himself cosmetic surgeon, make sure that they are a board certified plastic surgeon. Results in aesthetic that match your desired outcome is the key here, because that's the make or break it with breast aug. Like it really is.
And that comes from education, looking at before and afters, good communication with your office, you coming in with a North Star or something you're shooting for, looking at your body balance, the type of result you want, a more projecting result or a little bit of a less projecting result, a little more natural. And even, which we don't use very often because they're texture, but like an anatomic shaped implant, if you really want to go that route.
If you really want to double down on the problem.
Yeah, in most cases. So, it's a multifactorial approach that really can make the best outcome. But all those boxes have to be checked. And I think that's where things go wrong, right? I mean, it starts with the communication from an office, and then they're not really listening to the patient. The doctor just flippantly does kind of what they want to do.
Well, or that doctor has an aesthetic that does not match your outcome. And that we see that. We see that in Denver. We see that. There are doctors who have an aesthetic that is different than ours. And the patients that go to that doctor have those kinds of outcomes. And that's just kind of how it is.
Right.
So that's...
Right. So maybe the better way to say it is that you want to go to someone who's more transparent about what they're trying to sell you.
Right. And that you feel like, and we are not the right surgeon for everybody. We've had patients come to us and then they go with the surgeon who makes everybody really big. And that's the aesthetic that they wanted.
It's totally fine.
And they thought maybe ours were a little too conservative.
Yeah.
Like, that's fine too.
Those are the funny patients because you show them the bigger ones, They're like, this is kind of a stretch. And they're like, well, what are you talking about? I mean, I'm starting from there and going up, It's like, maybe we're not the best fit in the world.
Yeah. I mean, but we're flexible to do that. Whereas there are some offices who aren't flexible to go the other way,
right.
to come down in size.
Yeah.
So, yeah. So someone you feel comfortable with is really key with this as well, as it is with any surgery. So some questions to ask your plastic surgeon. We always, you link these, correct, Nils?
Yes,
you put these, they'll be in the description box. But there's a couple with this one that are kind of standouts. And I had them bolded when I sent them in. And they're really the things that are more related to the implants themselves. So, you come in for your pre-op appointment, they're going to go over your health history, give you a quote, talk about the risks, show you before and after pictures, answer your questions. So some questions that you should ask your surgeon specifically about this surgery is, how many additional implant-related surgeries can I expect over my lifetime?
Oh, very good question.
What would you say?
I mean, you don't know.
Right. How old are you when you start?
Yeah.
That's going to play a part in it.
FDA wants us to tell you 10 years. It could be every 5 years. It could be in 20 years. You just don't know. But you just have to expect you're going to have one or more surgeries in the future if you're relatively young.
Even if you're not. I mean, we have patients who come in and they're like 60s. They're like, well, this is the last time I'm doing this. I'm like,
Yeah.
how long do you want to live? And we've had patients who have had the need for additional revisional surgery within a year of surgery. And we have other patients who come to us who've had their implants for 30 plus years and are only doing something now because they want to lift.
Right.
You know, like they've had no issues. Here's a big one too. And this is something you may not think to ask. Will my ability to breastfeed be affected?
Could be.
Yeah, you don't know.
We don't know. It's, you know, at least the way we do it, probably unlikely. It probably still can breastfeed, but it could be affected. Maybe you can't breastfeed as well. So it's hard to predict that.
Yep. And if you've never breastfed before, this is what I tell women also is that you don't know whether or not you would have had those issues with or without the implant. So you don't know. If you've never tried to breastfeed, you don't know if you could. So
we'll talk about this like on the next episode, but in most cases, breast augmentations are underneath the muscle, which in theory is not going to affect the ducts themselves underneath the nipple and areola and the nerves that come from your chest wall on both sides and feed that area. But if you go above the muscle, which is called a pre-pec approach, it may affect that area more. It may be more likely, but there's really not a lot of data on that. So
no. And I think part of that is just because there's very little data on women who have multiple pregnancies and with a primary breast aug in between those that affected things. And again, you can have issues breastfeeding the second time, even if you didn't the first time, and like vice versa. Like it just, you don't know for sure. One other important one I think here is what can you expect your breasts to look like or how they can age over time after pregnancy, after weight loss? Again, it's hard to say, but it will affect them, as will aging and life and everything else. So
as long as you know that with aging, with weight loss, with all these things, your breasts will change, then you don't feel like you're getting ripped off.
Right.
Like I think that's the most important thing. And you may need a lift in the future. A lot of people,
most people do, even if they don't have implants.
Right. I'm not saying a lot of people, but a subset of women are like, I never want to lift. I get that. And you don't have to have one.
Nope.
But if you want to have kind of that perfect contour, middle-aged, post-pregnancy, in a lot of cases, you're going to need a lift either with the augmentation or at some point in the future. We get exceptions to the rule all the time.
It happens. It's rare that we see a woman in her 50s who doesn't need a lift.
But I've seen it.
happens.
I've seen it. But it's unusual.
Yeah.
It's unusual. So
it's like seeing someone in their 60s who doesn't need a facelift. It's rare.
Seen it.
But those outliers exist. Yeah. All right. So that about does it for part one. Part two, we're going to come back and talk about I would say call it the meat of it, but that always sounds wrong. We're going to talk about the actual specifics of surgery and what to expect for recovery.
Stuff that really matters.
How to choose an implant.
Yes. This is the part that matters.
Well,
Amy.
this part mattered though. This is where we told people the truth.
Yeah, that's true.
Yes. This is the things that maybe you didn't actually think about. So this is probably the most important one to listen to.
Yeah, I agree.
But everybody will want to listen to part two. Everybody likes hearing about surgery.
All right. Can we just do part two now, or do we have to wait 2 weeks?
I'm going to wait 2 weeks.
Ugh.
Yeah.
Okay.
So until then, if you would like to leave a comment or send me a voicemail, you can do that at 303-630-9038.
And you didn't even did you look down?
I always look down.
Oh, okay.
I don't trust myself.
It's sneaky though.
It's, yeah.
She's almost like a newscaster level.
Yeah. Like I'm
Skills.
looking down. Yeah, and we would appreciate it if you would like this video and share with everyone you know who is thinking about having a breast augmentation, because like I said, this is really important stuff that they probably aren't hearing on other places.
Yeah.
Or they're only hearing the scary bad part of it and not the real truth of it. So.
All right.
All right, until next time.
Good part is coming next.
I'll see you then.